choline esterases product acetylcholine from the hydrolysis. So these are known as the anti-choline esterase agent. They are also the cholinomimetic agent, but the action is due to the inhibition of acetylcholine esterases. So these produce cholinergic effect in vivo. In vivo means inside the body, and potentiate acetylcholine in vivo and in vitro both. And some anticholinesterase have been additional effect on the nicotinic type of the receptor, or else many of the action is brought about by the muscarinic type of the receptor stimulation. And here you can find two type of the agents. One is the reversible agent and another one is the irreversible agent. So some agents are binding with that of the acetylcholinesterase reversibly, and these are called as the reversible agents, whereas some agents like this OPC and other compounds, they will act irreversibly, whereas the reversible agents examples are many examples. Please remember the physostigmine or esarin, and the neostigmine, pyridostigmine, adrophonium, and rivastigmine, donepezil, and galantamine are the carbamates. This is the carbamate category of the anticholinesterase, whereas some of them are the insecticides also, and the acridine compounds are tacrin is the acridine compound, whereas the irreversible agents are two type of the compounds. Once again, the OPCs and some of the carbamates are irreversible acetylcholinesterase inhibiting agents, or diisofluoryl phosphate or diflos is one of the important organophosphorus compound which is going to irreversibly block the acetylcholinesterase enzyme. And ecothiopate, the malathion or diazinon, a famous TIC20 is there, and tabun, sarin and soman, these are the nerve gases, especially they are used in the Second World War. And the above one, especially malathion, DFP, ecothiopate, these are all the what you call as the insecticides. They are the insecticides. And the carbaryl and profoxure are carbamates class, whereas the began and savin, all these are the carbamates. And these are all insecticides. They are very potent agents and highly toxic agents, especially the OPC compounds and the carbamates, whereas the reversible carbamates are less toxic, whereas the irreversible carbamates are highly toxic. And here we can see now the very preliminary structure of the carbamates and OPC. In most of the organophosphorus compound, the phosphorus moiety is there with the 3 chains R1, R2 and R3, whereas the phosphorus moiety, it makes whether the compound is reversible or irreversible, inhibiting agent of acetylcholinesterase agents. And all these anticholinesterase react with the enzyme acetylcholinesterase and act very similar to that of the acetylcholine, or they are the cholinomimetic agents. The carbamates and phosphates respectively carbamylate and phosphorylate the esteratic site of the enzyme. So as you know very well that the enzyme acetylcholinesterase got this anionic site and esteratic site, and both of these are going to bind with esteratic site, and sometimes reversibly and sometimes irreversibly. The mammalian anticholinesterase has been cloned, and details of its structure as well as mode of the action with that of the acetylcholine and anticholinesterases have been already, they are studied in very depth. The active region of acetylcholinesterase forms a complex which contains anionic site and esteratic sites. Two sides of the enzymes are there, and the hydrolysis of the acetylcholine involves the electrostatic attraction of positively charged N plus of the acetylcholine to anionic site, then nucleophilic attack by serine OH moiety, which is activated by adjacent histidine, leading to acetylation of the serine. So because of this thing, the acetylcholine gets activated. The acetylated enzyme, the enzyme acetylcholinesterase is becoming acetylated, reacts with water to produce acetic acid and choline. That's how it is going to cause the metabolism of the acetylcholine, the potent neurotransmitter of the cholinergic nervous system. And this is a schematic diagram representation of the reaction of acetylcholine of the carbamate and anticholinesterase, whereas the E and F are noted here. Carbamylated, there is a lot of difference between the carbamylation and this phosphorylation. Phosphorylation is irreversible, whereas the carbamylation is reversible. And it is going to act with that of the cholinesterase enzyme, acetylcholinesterase, and reactivation of phospholipid enzyme by the serine, histidine, and glutamic acid. So you can see that the enzyme has got two sides. One is the anionic side and esteratic side, whereas the acetylcholine enzyme will get the complex with that of the acetic acid and choline. Then the acetylated enzyme rapidly it's activated or it is metabolizing the acetylcholine into acetic acid, and the free enzyme is free acetylcholine esterase. Whereas especially in case of certain carbamate compounds, it is going to bind with that of the bind with that, especially the carbamylated enzyme is completely going to release the substituted carbamic acid and free enzyme is released. Whereas the phosphorylated enzyme is not free, is going to irreversibly block the what you call as the this anticholinesterase enzyme, and whereas the oximes, parallelodoxime, obidoxime, and many oximes are going to activate this inactivated enzyme. So many times if the enzyme is inhibited for prolonged time, then aging becomes. So that you can see in this particular diagrammatic representation. And pharmacological actions of inhibition of acetylcholine esterase causes due to the amplification of endogenously released acetylcholine. So we are not going to administer any exogenous acetylcholine, but endogenously released acetylcholine will be released. This enhanced action or the amplification, because acetylcholine esterase or anticholinesterase is a very specific enzyme going to bind with that of the acetylcholine and going to cause or destroy the acetylcholine into acetic acid and the choline, whereas the choline is uptaken into the presynaptic terminal, whereas they are qualitatively similar to those of directly acting cholinesterase stimulants, especially the anticholinesterase. Anticholinesterase activity is very similar to that of the cholinergic stimulators. And many times the lipid soluble agents like physostigmine and OPCs, physostigmine among carbamates and OPC, and all OPCs are usually lipid soluble, have more marked muscarinic and central nervous system effects and stimulate ganglia, but action on skeletal muscle is less dominant. So usually they are going to stimulate the ganglia, wherein which both muscarinic and the nicotinic type of the receptors are there and going to stimulate. And because of this thing, the marked effect on the skeletal muscle, direct action on the muscle and inflate cholineceptors as well, stimulate the ganglia, but muscarinic effects are less prominent, even though it's going to act on the muscarinic receptors. And as other thing, they do not penetrate the central nervous system and have no central effect, especially the drugs. And the ganglia, local hydrolysis of the acetylcholine esterase is less important in ganglia. Inactivation occurs partially by diffusion and hydrolysis in case of the plasma. But muscarinic effects are less prominent and they do not penetrate the central nervous system and have not got any central effect, whereas the ganglionic effects are very much prominent. And anticholinesterase agent stimulates ganglia primarily through the muscarinic receptors present there, and high doses causes persistent depolarization of the ganglionic nicotinic receptors and blockade of the transmission. Whereas the cardiovascular effects are very similar to that of the administration of cholinergic agents, but it's a little bit complex when compared to those agents. And muscarinic action would produce bradycardia and hypotension as usual through muscarinic receptor. Whereas the ganglionic stimulation would tend to increase in the heart rate and BP due to the involvement of the adrenergic nervous system. And thus, the overall effects are often unpredictable and depend on the agent and its dosage. So, after treatment with anticholinesterases, the acetylcholine released by a single nerve impulse is not immediately, it is destroyed. And the force of contraction, especially of the skeletal muscles, impartially curarized and myasthenic muscles is increased. That's how the thing, especially the effect of the anticholinesterase drugs on skeletal muscles. So, in the higher doses, suppose the toxicity of the OPC compounds, then it is persisted for depolarization for prolonged period, resulting in blockade of direct action of the neostigmine and its congeners at the muscle, and it's result in augmentation of the all these features, and the neurotransmission of the neuromuscular junction, it is causing weakness and paralysis. It is going to inhibit. And the central nervous system, lipophilic anticholinesterases, which penetrate into brain, produce generalized alerting response, whereas the cognitive functions, especially of the brain, may be improved in Alzheimer's disease. So, Alzheimer's disease is a one, there is a dementia or loss of memory will be present, and however higher doses produce the excitement and mental confusion, disorientation, tremors and convulsions followed by coma. And coming to the pharmacokinetic of these agents, the first one, very simply I am going to explain it within 1 or 2 words, otherwise if you read the Goodman-Gilman and other thing, you will get a huge explanation. For a undergraduate, I think you have to know 1 or 2 lines how physostigmine is absorbed from GI tract and parental sites. It is going to rapidly absorb from GIT and parental sites, and it is applied to the eye and it penetrates the cornea freely. Then it crosses the blood-brain barrier and is disposed after the hydrolysis of choline esterase. That's one of the important action. Whereas the neostigmine and congeners, all this neostigmine, physostigmine and organophosphorus are belonging to anticholinesterase agents. Whereas the neostigmine and congeners are poorly absorbed orally, and the oral dose is 20 to 30 times higher than the parenteral dose. Usually it's always like that. Then they do not effectively penetrate into cornea or cross the blood-brain barrier, whereas the physostigmine crosses the blood-brain barrier. And they are partially hydrolyzed and partially excreted unchanged in the urine. This is a very short pharmacokinetic parameter of the agent. And OPC compounds are absorbed from all sides, including the skin and lungs. So please see that the organophosphorus compounds, especially the malathion, parathion, sumithion, and monocrotophos, etc., all these are the organophosphorus compounds. Any compound ending with phos, like monocrotophos, dicrotophos, malathion, sumithion, parathion, all are organophosphorus compounds. And whenever these drugs are spilled on the skin, they are going to be absorbed into the circulation to very high quantity. So the toxicity is caused, and they are hydrolyzed as well as oxidized in the body and little is excreted unchanged in the urine. So this is the kinetic. Means why it is important to know the kinetic is, suppose the organophosphorus compounds, you have to get remove the toxicity. Means you have, if the organophosphorus compound is spilled on your skin also, it is going to penetrate from the skin's this side, and if you inhale the particular compounds and through the lungs, it is going to be absorbed. That's why whenever these pesticides are being sprayed, you will get giddiness and some cholinomimetic reactions are also obtained. So be little careful or while handling such type of the agents, especially the anticholine esterase OPC compounds. And comparative features of the physostigmine and the neostigmine is like that. The source of the physostigmine and neostigmine, the source of physostigmine is natural alkaloid from Physostigma venenosum, or it's also known as calabar bean, whereas neostigmine is a synthetic agent. The chemistry is the tertiary amine sensitive derivatives, whereas the neostigmine is a quaternary ammonium compound. That's why orally they are not so well absorbed. And the CNS actions are present to the physostigmine, whereas it is absent in case of the neostigmine. And the applied to the eye, what happens? The penetrates the cornea, whereas the neostigmine is not penetrating properly. Whereas the direct action on the nicotinic muscarinic cholinomimetic agents are absent, not nicotinic muscarinic, neuromuscular blocking agents, and present in case of the neostigmine. And the prominent effect on autonomic effector, whereas the prominent effect of neostigmine is on the skeletal muscles. So the important uses of the physostigmine, its meiotic nature or glaucoma, it is a useful agent. And the dose, especially the neostigmine, is useful in the myasthenia gravis. I am going to tell what is a myasthenia gravis in future. The dose is 0.5 to 1 milligram, that oral, and parenteral, it is the dose is the same, 0.5 to 2.5 milligram subcutaneous of the synthetic agents. Duration of action of the physostigmine is 4 to 6 hours, whereas it is 3 to 4 hours in case of the neostigmine. And physostigmine eye drops are very commonly used and prepared freshly in the ophthalmological preparations, whereas the pyridostigmine resembles neostigmine in all the responses, but the dose is dose to dose less potent than the longer acting, and less frequent dosing is required, especially in case of the myasthenia gravis. And embenonium is another drug which is belonging to the same category, long acting congener used in the myasthenia. And edrophonium resembles neostigmine in action, has a brief duration, and suitable only for diagnostic agents of the myasthenia gravis. Edrophonium, especially, it's used in case of myasthenia gravis, in which the antibodies are developed against the receptors. And tacrine is a lipophilic acridine dye compound which interacts with cholinesterase, acetylcholinesterase, in the manner analogous to the edrophonium. And the tacrine crosses the blood-brain barrier and has got a longer duration of action. That's why by increasing the brain acetylcholine levels, it was found to produce some symptomatic improvement in Alzheimer's disease, wherein which there is dementia or loss of memory will be there, especially in the geriatric patients, and but it is having lot of hepatotoxicity, and any drug which is having some effect on the desired effect, many times it will have more and more the untoward or undesired effects. And rivastigmine is another drug, lipophilic, relatively related drug, and it's also a cholinesterase inhibitor. So this rivastigmine is also used in case of the Alzheimer's disease. And donepezil, as we have listed earlier, it is another centrally acting anticholinesterase that has produced cognitive and behavioral improvement in the Alzheimer's disease. So it is long acting and suitable for once daily administration, because most of the other drugs they require the twice daily or thrice daily administration. And galantamine is the natural alkaloid inhibitor of cerebral anticholinesterase, in addition to weak agonistic action on the nicotinic type of the receptor, especially in the neurons. It is being used for the symptomatic relief of the Alzheimer's disease. And diflos or diisofluoryl phosphate, it's a very potent and long-acting anticholinesterase the agent. So it is a highly toxic agent. So it is obsolete. And ecothiopate is an OPC compound, but it's having quaternary structure, it's water soluble, and was used as a long-acting meiotic. And precautions, the anticholinesterases are contraindicated in sick animals because of the AV conduction defects and hypotensive states. So these should not be used, and they are to be used very cautiously in people with peptic ulcers, asthma, chronic obstructive pulmonary disease, and seizure patients. So many times we are going to use them in the Alzheimer's disease and other conditions, but in certain conditions they are highly contraindicated. But the margin of safety of these agents is very low. That's why they are highly toxic, and one should not use them unless it's very much required. And uses of these agents as a meiotic, especially in case of glaucoma, it's used. Meiotics increase the tone of the ciliary muscle attached to the scleral spur and sphincter pupillae, which pull on and somehow improve alignment of the trabeculae, so that outflow facility is increased, so that the contraction occurs and glaucoma is reduced. And pilocarpine is the preferred meiotic, and the action is rapid and long lasting. 4 to hours and 6 hours to 8 hourly installation is required, and even it can also be used to induce and may fluctuate in the between.